It was counterintuitive, but because we had concrete and objective data, the team felt confident in making this decision. If we were going to do that in a regular NICU without Enlight technology, that would have taken us 3 weeks to accomplish. We saved 3 weeks of time and 3 weeks really of lung over distension. And I think there was such excitement over that patient that we could change the course of care for that patient, that the acceptance really took off. This was a neonate who was born prematurely at 26 weeks gestation. He had already had a tracheostomy and on significant levels of ventilator support, and despite that, was having periods where he would have no ventilation and desaturate and become bradycardic and need chest compressions. There was a lot of moral distress with our staff. Our team was very worried about the baby's suffering. These periods were frequent, they were severe, and it seemed like the baby was in pain, and that's why our team had such a difficult time caring for him. As people were expressing their feelings, I thought, are we doing the right thing with the ventilator? And I said, I wonder if Enlight can help us here. We were able to the next day bring Enlight to the room and do a full assessment of where the PEEP level should be. This baby had severe bronchopulmonary dysplasia, which is a heterogeneous lung disease, meaning that some areas have low compliance and they inflate easily, but they deflate rather slowly. Other areas have high airways resistance and premature airway closure, in which some of the gas is actually trapped. So it's a very tricky disease to ventilate, especially as we're wanting these infants to be awake and breathing and active and interactive with their environment, with their parents. It's very difficult. When we first approached this baby, who was mostly sedated when we brought Enlight to the bedside, he was on 14 of PEEP and somewhere between 70 and 100%, and his saturations were very labile. When we put the Enlight belt on and titrated the PEEP, we could see actually that 14 of PEEP was too high. Without Enlight, we were faced with a situation of clinical hypoxia, and in that scenario, it's very difficult to turn the PEEP down, right? Everyone wants to turn the PEEP up. And so it was counterintuitive, but because we had concrete and objective data, the team felt confident in making this decision. So we turned the PEEP down to 10 centimeters of water. If we were going to do that in a regular NICU without Enlight technology, that would have taken us 3 weeks to accomplish. So we not only got the baby on the optimal PEEP level, but we saved 3 weeks of time and 3 weeks really of lung over distension. The next day when I came back to check on him, he was still on 10 centimeters of water and his FiO2 was down to 37%. He was able to be transitioned to a bronchopulmonary dysplasia care unit and then to rehabilitation, and happy to say he's since gone home. And I think there was such excitement over that patient and such excitement that we could change the course of care for that patient, that the acceptance really took off.